Was this Denver? I don't know what this is. Oh, it is Denver. Denver,
Oh,
Starbucks.
nice.
I made this though. I made this coffee because
No, I
I
thought you
found it
made the
like.
cup.
No, I did not make the cup. That would have been awesome. But I guess they had these versions like in every city, and so friends of ours got us ones from Denver, and then I have a Seattle one, and I think I have one other one, but I can't remember which one it is. I'm not a big coffee drinker, but I do like a latte, so that's what I made
Naturally.
myself this morning.
Did you have like a
And I have my
professional
new
latte
cardigan.
maker?
What do you think?
Uh,
It's very festive.
it's representative of the Galapagos Islands that you just recently
that's,
visited.
that's right. That's right. Um, yeah, what a trip! Holy crap! What a trip! Unbelievable. I did not really know what to expect, if I'm totally honest. It was my wife's kind of dream trip, but it was incredible. And I would say that uh, one of the coolest parts was we were snorkeling with my oldest, who's about ready to be 15, and we're in this cove, and it was kind of this island called Santa Fe, which is known for sea lions, right? So our guide's like, "Hey, the sea lions are really active today. Like, we should go over there and just see what'll happen." I was like, "Okay," like I don't know. So we're over there. The sea lions started grabbing our flippers and trying to like take them off with their teeth, like under the water, right? Like just playing with us, like messing with us. And I'm like, "This is." I'm watching it happen. I'm like, at first I'm like freaked out. I'm like, "This is too much." And then I was like, "This is." I mean, this is the most amazing thing I've ever seen in my life. And they were like playing with my daughter. They came like right up to her, and like looking at her, and I mean like this close to her. It was unbelievable. And she's
That's
like no
awesome.
fear, right? Like she's just like, "This is awesome." They're like coming up between us, like right, like just sneak up from you. And it's not like little ones. It's like these are real sea lions. It's like,
Right?
yeah, it was amazing.
That
Very
sounds
cool.
awesome.
Yeah, it was an epic trip, and Colombia was awesome. We did Bogota like for a weekend, and I was so glad we did it. Very cool city. It just the food scene was off the hook. We loved Quito, Ecuador. Like that was awesome. Like I could totally see going back to both places. So it was super fun. It was great.
Well, that's awesome.
So everybody, thanks for joining. This is my good friend Kelly Clockler Thornton. I always say Clockler Thornton, but I don't know what are you going by in the last name these days?
At work, I always go by Kleckler because I've always done work at UT Southwestern. It was just easier to keep it
Oh,
than change my name. But
right.
technically, I've been married it'll be 20 years this year, so kind of weird that I still use my maiden
That's a
name.
long time.
Like
It's a long time to be like,
I didn't change it for the first like 5 years. I wanted to make sure it was like a permanent deal. I didn't want to go to all that trouble.
I won't. We won't. This is live. You know that, right? We won't. So hopefully, your husband's not listening. I mean, I know your husband. He's a good guy. So
He's an awesome guy.
I'm hoping this sticks around, but I'm not sure I want to change this yet.
Well,
I'm
It's,
not
it's
committed.
15 after years plus when I changed it officially.
Yeah, you're pot committed now. It feels like.
We're pretty committed.
Yeah, bought a house, bought a new house. Just
Bought a new
fantastic.
house,
Oh, exciting.
downsizing.
All right, so you don't have a cardigan on. You have like some kind of jacket, and then
It's
you don't have a
actually,
coffee.
I have a Red Bull. This is my drink of choice.
I'm 0 for 2 on this.
This is actually a sweater.
Cooper
It
didn't have
is-
it either. He's like had some kind of sweater thing. It looked cool, but it wasn't like. I'm like, I don't think that's a cardigan. I don't think it counts. But whatever, that's
Well,
fine.
kind of a
All right,
cardigan.
Kelly, tell us what's your role and where you work at, because I'm not everybody knows. So just like you're over Rev Cycle, I know that, but
I'm over Rev Cycle at UT Southwestern Medical Center in Dallas, and my role consists of professional billing, hospital billing,
Central access areas.
pretty much the whole gamut of
the whole
revenue
thing,
cycle.
the
The
whole
whole
thing,
thing.
the kit and caboodle they call it.
Yep.
Fantastic. So, tell us like, I would say like my usual start to this is like, what are what are you stressing about? I would, I know you're not on change because we've had this conversation, but I can't help but not talk about it because it seems like, yeah, just a disaster. And I don't think we will fully realize like how much of a disaster it's going to be. not people and people outside of our general scheme, right? Most people within are realizing like how bad this is going to be. Um, how is that treating you guys? I know you're at different. You're on Waystar, is that right, or somewhere
Yeah,
else?
we're on Waystar.
But
So
like,
we do have retail pharmacy, which is a direct connect to Change. So they're definitely offline right now. So it's hard to fill prescriptions and understand people's benefits and that piece. And then even when you're on Waystar, there is some payers that Waystar actually sends to Change. And so the impact's been minimal, but I guess for me, it just makes me realize, like, as much as I love technology, and I'm the first to jump on the technology bandwagon, it just lets you also, as a reminder of how vulnerable, your organization is, or even the organizations that you deal with, and like, kind of puts into perspective, like, contingency planning and just what would I do? I mean, it could happen just as easily to my clearinghouse as another clearinghouse. So you start thinking, like, if this had been me, what would I have done differently? What could I do? So I do think you have to kind of think. We both have a friend who, they had the same issue, but it was inside their organization.
right?
I mean, devastating.
Yeah, I can't even. It's like hard to process like how devastating this could be for an organization. I can't even imagine what the change people are going through. I heard a rumor from a friend that basically they can't even access their own laptops.
Well, I mean,
So,
when I talked to the person whose organization got hacked, they couldn't log into email. They couldn't then send email outside of their organization. Remote connections, all of that. So, what that does is impactful at a whole different level.
I mean, it's interesting on so many levels because we've, as we've been talking about clearinghouses over the years, it started to become like, well, it's a commodity. It's like a race to the bottom of like how cheap it could be for providers. But now this puts it in a whole nother light or perspective of like, well, I was talking to Nate Pluki yesterday, Nate from Switch. He's just really smart in this area. He helped build like healthcare IP's product. And he said one of the things is like, that maybe the future of this is that we actually have like brokers who help you. You don't necessarily have one clearinghouse. You just have whoever can kind of do what needs to get done to get to different payers because of the fact like you have to have. It's kind of like how many people have had an offshore operation in Bangalore, Chennai, and then like a flood happens and it's freaking gone.
Right.
Or it's out of commission for a month and and so then you have to have these like, so all like AGS, all those guys have got stuff in the Philippines and now Costa Rica, and now Bogota is like the hottest place to build a service center, which I totally understand why now. It's like educated population, 11 million people, and it's safe now and it's awesome. Like, and it's the same time zone as Eastern time zone. So it's, I could see why contingency plans are like that, but we've been so reliant on these big, even just like, and this is no shot against anybody, it's just like the reality of like, well, using one company to do lots of different things for you. Well, the risk and the nice part is like you've got one company to deal with. But I'd be curious to know what your thought is on that, because that's been a strategy for people. Is like, well, I only want 3 companies to deal with.
Well, I mean, so when we implemented Epic a long time ago, we actually did have multiple connects to different payers. I think we went direct to Medicare and Medicaid. We went direct to Blue Cross Blue Shield through Availity. And then we had a clearinghouse that kind of did everything else. And I think one of the issues is that for IR to manage all those connections without somebody, I mean, they physically manage like what, where. It's something that puts a lot of stress on them.
Yeah. Right.
But I do think, though, I mean, you know how I feel about our connections, and kind of, I think that payer platform with Epic is, being developed for the right thoughts and us being able to connect directly to payers. It's not happening near fast enough, but that's also, I think, kind of, to a certain extent, what Epic was thinking was, can we just go direct to the payers and get things like that done? And so I don't think it's going to happen in the next 2 or 3 years. But eventually, I do think that is kind of what they were thinking.
But it doesn't solve any of the current issues.
Right.
It doesn't solve the current problem, but it does. I don't know. It's always kind of like going back to like, well, if your eggs are in one basket, it is like that basket gets hit.
You're vulnerable.
What happens? You're vulnerable. I mean, I think at this point, what I'm gathering, enough intel I'm gathering, and I can't say all of it, which is I just feel at this point it's like I'm not trying to be. I'm also trying to be like hesitant. Like I don't know all the information. Some of this is getting third party. But it does feel like this is not going to be, this is 100% not like, oh, it's going to get solved in 3 weeks. It's like, no, this may never get solved the way we think it is. And like people are asking about a loan program from Optum. I'm like, they're not going to have enough money at some point. This is going to be another government that's going to have to step in and do some type of bailout for places. Like it might only affect you 10, 20% of your payers because we got the list of payers, which I do have, by the way, from our town hall. We got the list of payers who use Change as their like intermediary, right? So there's no other way to do it. You'd have to go through Change. That's why everyone's kind of affected by this in some way. It only affects you 10 or 20%, but what if you're somebody else and it's affecting you 80% or more, right? Like, you're going to run out of cash at some point.
Cash, but I was just about to say, a lot of us are not in a cash position where we can
let that be extended very long.
I mean, what days cash are you guys like right now?
I honestly don't know what we have in reserves or any. I mean, I collect the money. I don't keep track of it after that.
I bet Mark's not sleeping real well these days. I mean, imagine if you have. I mean, we had some people in town hall and we asked the question like how nervous are they about cash position? Extreme to very to like 40-some percent, 44% or something said very or extreme. The rest weren't as concerned. Most people in the middle. But like you said, I think well, if you get 180 days of cash, you feel like, oh, I feel fine. But what if you had like 90 days? Because you started with 90 days in cash, and then all of a sudden you're at like 30 days in cash pretty quickly. Like at some point you're going like, well, you got to make payroll.
Well, because even like getting back online after all this, I mean, you have to go slowly, and it's like step by step by step by step, and it's an extended process that can take
30, 90, 120, and that might even be being generous before you're back to where you were.
Yeah, right. Like think about AR, like AR days numbers. Like what's your days in AR going to be like looking like? I mean, we're going to see people in the 80s and hundreds probably, easy. And Nate made another good point around just being like going direct to payers, like you managing a direct to payer. Well, how many IT groups do you know like have done that and can manage it effectively? But plus it opens you up for a potential like, what if you got attacked?
Exactly. Well, I mean, there is value in the clearinghouses. They build a lot of rules for us.
100%, right.
Help us submit clean claims, and so
you do lose some of that functionality if you did go direct to payer. So
yeah, for sure. I was just thinking more like in the interim, people like thinking that's a strategy. We hear lots of people from people printing out like high-dollar claims and sending them paper. It's like, I mean, you got to do what you got to do at some point.
Well, I mean, even, for what we're doing, even with Waystar, they've printed some of our stuff out and sent it.
Yeah, right. But they're, all these other companies are getting bombarded too. It's like, yeah, it should be great to just switch to somebody else. How long is that going to take? And
right.
How many requests are they getting to do the same thing? And all good people. I think they're trying to help, like Waystar, Office Ally, like Experian, but I don't know how much bandwidth their teams are going to have. They're going to quickly tap out.
Well, I mean, it's two-way, too. So you've got the claims that go out that are now going to be delayed cash back in the door. But even the cash you would have gotten during this time is held up. And while maybe the cash is in the bank, you still have a mess in Epic because you can't post the cash. And you got people following up potentially on claims that were already paid. I mean, it's just a lot of
claims.
internal workflow reconciliation
it's not easy to do.
Not easy to do. Yeah, and I'm not trying to. I think this one thing is like, well, I'm not trying to be like, what's the word where you're like make something bigger than what it is. Like, I'm not trying to make it sensationalized. It's like,
Right.
no, I really do believe this is like this could be just a major problem for everybody this year. And I say this year, it could take the whole year to kind of get back to somewhat normal for some people.
Yeah.
Love to hear people's comments about our live. We're live, so if you have comments or questions, like put them in the chat. I actually asked Tina. Tina's helping kind of manage that because I tried to do it last time on my own and it was not great. I missed a lot of questions, so please feel free to put stuff in there. We'd love to take your questions. Well, besides that, what's stressing you out? What's keeping you up at night in Rev Cycle these days?
I don't know that I'm stressed out about it, but we have really been focused on denials prevention and how far up in the chain can you really effectively, either reduce denials, but even more important, how do you more effectively do reporting in a way that you can actually understand root cause. So we've been very focused in
making sure, one authorization denial is an authorization denial, but what's really the root cause of that? Is it because you didn't get all of your codes done? Was it a gap in, authorization for an infusion? Was it, spell of illness? So what really was at the root cause that you could potentially go back and know how to do preventive measures? So we've been very big in making sure that we have root causes built out in Epic so that we can do better tracking on that and hopefully get to where we need to fix problems versus just
kind of thinking everything is the same. So that's been our biggest focus lately. And then I guess our second focus is really how do we use new technology to improve our processes and potentially speed up processes and do better work. So we've been exploring stuff with generative AI and clinical appeals and things like that. So that's kind of not a stressor to me. It's just exciting things and just understanding how this works and how we can use it to our advantage.
Mm-hmm. On the first one, I want to talk about both those, but on the first one, are you seeing are kind of like the stats would say that all the clinical denials and medical necessity, those types of things have gone way up. Are you seeing a similar thing in your neck of the woods? Are you seeing a similar kind of progression in the last year and a half?
Oh, absolutely. So
and what's the major topics? Like, what are the major themes that you're seeing that are like, we never got this many of these before, like what's going on?
Yeah, so,
authorization, MedNec are my two biggest focus areas because it's where we end up, our turnover is not as high, so we've got to prevent it so that what we do get, we can turn over, and we get more. So using authorization as an example, there's devices and supplies that require authorization. So even though you got paid some portion of the claim, there's still big carve-out items. So making sure that we identify those early, put them back into the ordering process so that when they generate an order for this procedure, I make sure the neurostimulator extension, all these things are accommodated. And they just can get into that minutia to where if you don't have good reporting, it takes longer to identify those. The second thing is really the medical necessity denials. So they're updating their policies all the time. So, your provider wants to do this surgical procedure that requires some evidence of something growing past some, centimeter or whatever before they can do it. So making sure that you understand those policies and then educate your providers to make sure that they understand kind of what those medical policies say before they proceed, because those are things I can't overturn if the documentation is not there. Or
are those experimental stuff or just kind of routine, but it just requires
routine procedure that has, certain requirements that have to have been met before they want you to perform that procedure.
Yeah, right.
And then, the level of service denials are a whole nother thing that are very hard to report on. But if they start, only paying me for an ED level 3 when I build an ED level 4, and I have to appeal that on the back end, not from a denial, but just from the fact that I know there's a variance in my payment, I've got to be able to do that pretty quickly and also make sure, obviously, the documentation is there to support it, or we wouldn't have coded it that way in the first place.
Right. Interesting. Sergio had a question. How are you leveraging analytics with payer behaviors?
So we have some...
The eternal question.
Right. So I think we have some pretty good report cards that we've been able to develop. One of the things that we like to do is to compare our managed care payers to the other BUCA payers just to see how they are stacking up. So how long does it take them to pay us? How long does it take them to respond to their denials? And then as a percentage of the claims we send out, how do they stack up against other places in the different areas from like an auth perspective? Are we getting more auth from one of them than we are from the others? So we have pretty good metrics right now to kind of use that. Where I've been less successful is proving the point that when you request, medical records documentation, I have an overturn rate of 90, usually between 95 and 98%. Why do you keep requesting documentation? Like, between the level of effort that I'm putting in to get that to you and the level of effort you're putting in to then review that documentation and pay me, are you really saving any money by putting that kind of administrative burden on both of us?
And so I've been less successful in like using that contractually to get that administrative burden reduced. But I think we have made some impact with some payers in just proving that their performance metrics as it stacks up to their peers aren't
meeting expectations.
So we do present a payer report card in our JOC meetings on a regular basis.
But are you seeing like actual behavior change? I mean, is it impact, like, just like you said, you're okay, you're asking for all these things, but every time I'm giving it back to you, you're overturning it 99% of the time, based roughly, right? So it's like, What are we doing here?
Yeah, I would say
does that go anywhere, or is it the wrong people in the room?
To a certain extent, it's usually
the wrong people in the room, and it usually ends up being, I'll take this back.
I'll take this back.
I'll take this back. So,
mm-hmm.
Yeah.
I don't know. I'm becoming very cynical on this subject, and I don't mean to be. I know there's lots of people like, oh, we can work together. Let's work on collaborating. I'm like, I don't know. Maybe it's like I'm getting too old. Like, I've just done too many of those JOC meetings, and it's like,
yeah. And I think
they never go anywhere. It's always lip service. It's like, well, let's work on this. And 8 months later, we're still talking about them trying to figure out how to like implement it. I'm like, what the frick are we doing here?
Well, I think that's why I've really jumped to, we have to prevent a denial. Like, I can't try harder in follow-up. Like, my people try really hard and we do our best. But if there's any way to prevent it, or at least rest assured that if that is what's going to happen on the back end, that I have everything in a row to support it, that's where I've really got to focus my efforts.
Yeah. All right. Sergio has a follow-up. Is there language from a contractual base that can be utilized against payers to combat the multitude of requests? But I don't know if there is. Like, I don't know what you could put in there, because in their mind they're saying, how do they put it? It's like payment integrity. That's how they put it.
Well, and I think the best that we've been trying to push for is just limitations on how far they can test the integrity. So how far back can you go back and request additional information or go back and audit payments? Because one of the most frustrating things to me is when we get paid and then 2 years later,
they have hired some new group to go back and audit their claims, and they're recouping money on
stuff they paid me 2 years ago. I mean, that seems a little
excessive. So we are trying to do more focus on just limiting how far back people can go, because that's probably the most frustrating thing to me right now is when I go back and I see AR and I'm like, why do we have AR in the books
And then I find out that just, last week they took money back.
The takebacks and audits are, I think, the thing that people are just like is blowing up because
Yep.
again, they're going to use this third party to try to like, who's incentivized is only getting paid on what they can recoup.
Yep.
Right? The whole system is like, really? That's how this works?
Yeah, I think the other thing I've been a little frustrated with lately is one of the payers we deal with pretty often is not doing a great job of keeping their eligibility in their system up to date. So we've seen instances where
We've gotten eligibility from, the interactions or the
places we're supposed to go check, and we've also gotten an authorization approved, and then lo and behold, 6 months to a year later, they want to come back and take it back and say that patient really didn't have coverage. And you're like, well,
don't you owe me something when I took care of your patient in good faith, thinking it was your patient because you told me it was your patient? And they can be like, well, we made a mistake. It really wasn't our patient, not our responsibility.
That's right.
And I do
okay.
271s that show an audit trail of like,
Right.
they lost coverage in May, but you told me in June, you told me in July, you told me halfway through August
that they were eligible, but then, that's how far you are behind with eligibility.
I said this on another podcast, but I'll say it again because it's so crazy to me. I was in another session somewhere, I can't remember where, and it was there's a woman behind me was asking a question about this topic, and she's like, well, we've had this, it's a big health system, and they were like, hey, we're a big health system, but they send the audit letters, they take the money back, but they send the audit letters about what it is about that we have to try to appeal to these like clinics that are like out of nowhere. So there's in mail, like a physical mail, right? So it's like it's going to some clinic. She's like, by the time it gets routed to us, we don't even have time. Like it's past the appeal date, and we've told them like multiple times, and I thought, oh my god, it's like another strategy, right? It's like, and we told them multiple times, and she said the response from the payer is, well, we use this third party, it's them. It's like pointing fingers at each other, right? Like, oh, they had the wrong address.
Well, or
they give you a DRG downgrade, and you ask, and so you basically wrote an appeal, justify it, and they're like, well, the criteria that you're using and we're using aren't the same. Like, well, can you share with me what you were looking? Getting information back about what criteria is, they do not disclose that at all.
So a lawyer stood up. A lawyer kind of just spoke up. He was in the room. He goes, hey, I just want to say probably the only avenue here is to actually sue them. That they haven't, you provided them the address, is to sue them to like put legal action. I'm like, that's why I probably get so cynical. It's like, that's the point we're at. Where it's like, I got to sue them to like, sorry, I don't know why that just did a bubble. I got to sue them to like, to get them actually to do something as simple as like send it to the right place. Like, We're not even having a discussion. That's a technical issue. We're not even having a discussion on whether the care was provided appropriately. Like, yeah. I guess most of us would, if you talk to most rev cycle people, my guess is they would say similar things like, I get it. There's bad players. We want to make sure the care being paid for and the care provided is the right care. I think everyone would say that that's relatively accurate. What we're at now, though, is basically if you look at the statistics, it's like the same percentage denial rate, and we've lowered the eligibility denials because we've gotten really way better at that, right? But correspondingly, they just made it up.
It all depends on if that was up to date when we tried to get the information.
Well, that's another technical issue. That's different all around.
Well, and it is frustrating
because, you see your providers and your organization taking such good care of patients and doing what's right for them that you would just want the payers to do right by them as well.
And I feel like there's so many, I don't know, this is like a long subject, but there's like case managers and UR people that are constantly working with the payers, be like, here's what's happening. It's like, there's that whole process. So for the most complex patients, like should be interacting with each other to be like, here's what's going on. And like that, there's lots of issues with that process too. I get it. But like after the fact, 2 years later, we're having that issue. It's like, that seems, don't come to me 2 years later. It'd be like, I don't even know what the corollary is. The corollary is like, I get my house fixed and because of something happens and an insurance claim, and they come back 2 years later and be like, "Oh,
we're not really going to pay for that
claim, and we're going to take those windows out now because like,
that roof on your house has got to go."
What are you talking about? We already had this discussion. You had someone come out. We talked about it. Like this. That would be the only. I can't even think of a good correlate. I don't know if it's a good example, but it's like that's probably a little bit what it's like. Except it happens on a scale, and so subversive. They just take it out of payments they're going to pay you now. I mean, it's like the craziest. I don't know. It's not even a request. That's my point. Would be like, it's not a request to be like, hey, we got to review these and you need to appeal it and then we'll see the money back. It's like, no, let's take our money back and then screw you. Good luck. Kind of. All right. The second thing we talked about, I know obviously we've, you're a member in Tarpon. You guys are big on RPA but AI is new. I think, like there's so many people saying they're doing stuff. Like, what are you guys trying to do with it at this point? I'd be curious to hear.
So we started out on a smaller basis. So
we have a payer who is downgrading E&Ms, but in the ED specifically. So we, number one, need to identify those. But one of the things that we can do is kind of justify our level of coding. So we've basically taken the coding guidelines that we go by to code an ED visit, and we can basically take the medical record and have them generate a clinical appeal that justifies why it was right to bill a level 4 versus a level 3. So this seems kind of simple, but if you ask a nurse to write that letter, it's going to probably take her
30 minutes,
30 minutes to 45 minutes to like
go through the documentation, check all the stuff.
Where AI can basically take that note
and do that
letter in about 5 seconds, and then she just has to double check that it's accurate and get it out the door. So based on, we didn't really know how many of these we were going to get. So we started looking at, if I get a lot of these, how can I get these done pretty quickly with the same staff? Because again, they're giving us new denials or new things that we have to fight. And I can't go out and hire a bunch of staff just to appeal all these. So that was kind of our first step. But the next step is really taking any kind of clinical documentation, any kind of payer policy for some of our denials that are more prevalent to be able to build that infrastructure. And it's a HIPAA compliant. We're building it within Azure to basically kind of spit out those clinical appeals and have our RNs still do the appeals, but the appeals would be pre-written, and instead of them having to create it, they're basically reviewing it, validating it, and getting it out the door. So the idea would be that now our clinical appeals nurses are 4 to 5 times more productive, and basically being able to put together those appeals.
Yeah, you could see where that starts to become. I know our mutual friend Jeff is working on something similar, but he's taking all their contract language and then language around all their requirements from each payer and putting that in the large language model and basically figuring out how to do the, like, what are you missing? If you line that up with what your documentation is, what are you missing based on their own requirements? Like, that is another level. Like, and I've seen it. It's pretty amazing. Like, he's just scratching the surface of what's possible there, right? But
well, and really where I think you want to go with that is
backing up even further to where, like, right now we kind of do queries based on a lot of inpatient stuff. We have, CDI projects, things like that, to like make sure that we document it accurately to
ensure that we're billing correctly. But
it's kind of like if there's a payer policy that requires something similar to like an ABN, how that's triggered to make sure, the diagnosis is specific enough to move forward with that order. It's almost like making sure if there's predetermination or requirements under the policy that those are adequately documented before it even goes out the door. So ideally, you're even moving this stuff up further in the process. So that's kind of like
phase one is kind of the back end, fight the good fight, but phase two would be how do you move it up into the front end to kind of make this stuff be more apparent? Because I can guarantee you my doctors don't know what those medical policies are. They're not out there reading them like we are.
Well, and you said earlier, like they change enough where it's like, I mean, you got to keep up with all the changes. I mean, I guess how I see AI in particular being utilized in the future, or like, you know, now in the future is like, think about like, I always think back to like, I had this person, Glenda. This was actually her name. Glenda was in reprocessing. Early in my career, I managed central sterilization, reprocessing. If you guys know what that is, I was over surgery and I had a few different things. It was early in my career. This is crazy to think about that I had this responsibility, but Glenda would have been there for like 50 years, and this is no joke. Like she was getting close to retirement, and she had to go out for like hip surgery or something, and she was gonna be gone like 4 months. And I was like, and Glenda knew everything.
Yep.
Right? And then I got into RevCycle later, and it was like similar thing where it's like Susie, I always use Susie. Susie had been here for 30 years, and she knows everything about Aetna and like whatever payer it was, and like all these little tips and tricks. And I'm like, holy crap! Like, how are we going to replace her? Which is one of the biggest issues with like moving offshore. When I did like offshore work, it was like getting that group to expunge some of the knowledge from Glenda, you know, like in this example, like it was very difficult. What I see AI being able to do is take, like you said, large amounts of data, being able to process and know all those rules instead of the million sticky notes we have around a screen, right? I mean, like that was commonplace for how long? It's probably still commonplace, or a list of things you need to keep track of for this, you know, this payer. And how we can utilize that technology to like basically make our people X more efficient because they don't have to be remembering all the things. It doesn't take like a brand new person to make them as efficient as someone who's doing 20 years. I'm not saying that. I still think there's some inherent knowledge, but it's like you don't have to keep that all at the ready. And I think that's where I see it being like, so I don't necessarily see it being like, oh, I'm going to eliminate 50 jobs. It's like, well, no, you're going to make people 4 times more efficient, but also much more effective.
Well, I think you have to be effective this day and age because you will be adding 50 new jobs if you keep doing it the way you're doing it, because every day our denials increase. So it's kind of like, how do we, you know, we have an increased workload, so how do we combat the increased workload without hiring 50 more people? I don't have a budget to hire 50 more people, but I also don't have the capacity to not work it.
Right. So you're doing a bunch of automation work. What is your kind of strategy in that work? You guys are building an internal program. Just like, what's your overall overarching strategy there?
I think just continuing to engage our end users to look for opportunities to kind of remove the minutia from their daily workflows. So, I think educating the end users to where they can identify when there truly is an opportunity that says, every time this hits my work queue, I always have to X. And if I didn't have to X, I could focus on, A, B, and C. And so making sure that people, I guess, understand that automation isn't there to replace them, but it is there to take off the day-to-day to where you have to use your brain to do the process versus doing repetitive steps. So, getting them to engage and really help us identify those things that are just steps that we have to do, but don't necessarily require a thought process.
Right. And you guys have been working to build an internal program that like continually does this, right? Which is what I would hope that most people are trying to do. So it's good.
Yeah. I mean, I think one of the things
that we've learned is it is more effective both in the analytics area as well as the
kind of
RPA area to find your really smart people that are interested in technology and in data, but understand operations and train them up versus kind of going the opposite way and hiring people that are technically smart but really don't understand anything about the back end. So we've been lucky to find those. And anytime we've tried to go the opposite way, it hasn't been as successful.
Right. Makes sense. Love to take some questions from people. Not a lot of questions this time, so put some questions in the thing if we can. In the interim, while I wait for that, I think, Kelly, I'd love to ask you about. We have done a couple times at Leaders Forum. You come up and you talk about how you stop point of service collections. So this was controversial at the time. It still probably is relatively controversial. Tell us a little bit how that's going and like what you've seen when you initiated it.
So I guess I will say that we had different leadership at different times that had a very different direction on how they wanted to take that. But also understanding that when we were more stringent and said, hey, we're not even going to let you have this appointment. If you don't pay your outstanding balance and pay for this up front, then we're going to have to reschedule you. Like, that's how strict we could have been at one time. And understanding that there are a certain population, I'm going to use our Medicare population, who it's not that they won't pay. In fact, they'll pay it as soon as they have all the information in front of them to make sure that everything lines up. So there was a lady that came to me one day and she goes, why do you guys always ask for money up front? She goes, 100% of the time I pay you when I get my first bill, but I don't want to pay you until I get a bill from you so that I know what's on that bill is correct, and an EOB from my insurance company so that I can match those up to make sure it's accurate. And sure enough, if you go back and look at her history, 100% of the time she paid us. So why do I want to put in a step that dissatisfies her when she's a good customer to me? And so we tested that theory just to see that if we give patients the option to pay up front, but we focus our efforts on educating them on what their out-of-pocket would be and why, were we more successful in creating kind of that relationship with the patient where they were comfortable in either going ahead to decide to pay us up front, or that they would be comfortable paying their bill because they understood why they got the bill. And so we started an initiative a while back that said, for our contracted patients who have in-network benefits, it's always going to be an option of if they want to pay anything up front. You don't have to. They'll come up, we'll ask, but if you prefer to be billed, we are 100%, happy to do that for you. And I think that also we've been pretty open with our payment plans to understand that not everybody can afford to pay $2,000 or $3,000 up front. But
sure,
if it's a reasonable payment plan, they'll secure it with a credit card and pay those on the back end. And we've seen that default rate is very low. But that kind of takes that stress off of, hey, I need an elective surgery. I need to have a knee replacement. My knee hurts really bad, but I can't afford right now to pay 50% up front, 100% up front. But they've been very good to us on the back end. So some of that stress that comes with not having to figure out how you're going to get the money, as well as worry about your health care and your rehab and all of that stuff, it's been very beneficial to our patients. And we kind of measure metrics in Epic so that we can see how we stick to where our peers are. And when we made that change to make it optional, our upfront collections was still very high. So we still had a pretty large amount of patients who do just choose to pay upfront, as well as our bad debt never decreased. So we didn't have more bad debt. So we found that patients paid it, and we didn't have any issues with our self-pay cash collections. But we did have a happier customer base.
I think I love it. I mean, I think what's hard about the situation is that there's some bad actors that have the money that never pay you. And then when someone like Marty's just implementing a system that almost everyone has something similar, that, New York Times gets a hold of it and then they make it into something that it's not. That's what's really hard. I think we're in a catch-22. I still go back to we didn't create the copay. like Heather and I talked about this a lot, is like, we didn't create this scenario. Why are we all of a sudden, like, if I'm in the 1980s, why all of a sudden are we collecting this? Like, I didn't decide that your insurance has a deductible or a copay. And I still think this is like crazy because it doesn't, again, if I go back to my house insurance, I'm paying the deductible to who? I'm paying the deductible to my insurance company. So I'm not paying. So I just think it's like, I don't know. The whole thing is just really crazy to me. It's like, how did we end up with the hole in the bill on this? So if I'm an insurance company, I'm like, yeah, pass as much as I can because in the contract, I'm still paying you a certain amount.
Yeah, exactly.
So I negotiate a contract and you're looking like, oh, I got good rates. And then you realize like, because remember, I don't know if we've done this math before, but if, let's just say you're collecting 98% of every insurance balance you should collect, or you're probably collecting a little more than that. If it hits to a patient balance, the average in the U.S. is like 35%. It has been. It's kind of stuck there. And I know some areas are going to be 55 or 60, but on a typical basis, excluding pure self-pay, it's like 35%. Well, look at the delta there. Right. If you just shift $10 million from what you would have got paid last year for payers and your $10 million of patients, you're going to collect, you do the math, $66.5 million less.
Yeah. Now I will say that recently we have started looking at, so within Epic, it tells you if you're a good payer to us.
Oh, they're doing that now?
So, yeah, so we can see how many times you went to bad debt, how long it takes you to pay us and stuff. And I will say that for those people who routinely don't pay us, we are looking at potentially flagging those patients and making some more stringent requirements because, the other people shouldn't, have to be punished for other people's bad behavior. So I don't want to change our process, but we probably are going to look at some opportunity for those who can pay, that don't pay, maybe being a little bit more strict.
All right, question from Bill. Kelly, in light of all the challenges we continue to face in healthcare, can you elaborate how you've seen your regular touch base meetings, your CFO change in recent years from what it was like years ago? Like, is it more of a big picture discussion or still about the KPIs?
So I would say I have probably one of the best CFOs to work with. He's very knowledgeable about revenue cycle. So we go through metrics with him on a monthly basis. We basically have our own little
hospital billing dashboard. And so we kind of go through
where we are with our pulse metrics, where we are with different things, and then we collaboratively kind of focus on where there's opportunity. So that's kind of where we got into the denials prevention. So we do dig down, and I do have very specific initiatives on reducing med-nec denials, reducing authorization denial write-offs. And so that's really where we come up with strategies for how we're going to do that. So I don't think my meetings with him have changed at all because he understands metrics. He understands days in AR. His expectations are real when it comes to KPIs. So he doesn't say, well, somebody else has, 10 days in AR. Why can't you have 10 days in AR? Well, do you want me to try to collect it? Because his philosophy is I'd rather have more days in AR and you appeal something to death versus give up and write it off. So he's very flexible. I mean, we do have good days in AR, but his expectations are never unrealistic when it comes to whatever the industry says is a good metric versus what he knows from the data is a good metric.
Yeah, so important. Yeah, that was a good question, Bill. I think I could see that, as the CFO role is changing, CFO role should be different than it was. I mean, definitely more involved in operations than ever before. I think that's the new kind of, new expectation for a CFO is that they're not just crunching the numbers, they're going to be active in things. Otherwise, how would you know? Like, how would you be good at that role? So,
and he just asks great questions. So, we pull up data, we go through data. He's just easy to work with.
Yeah. Well, a testament to you staying as UT Southwestern as long as you have.
Well, he's very supportive too when I have
that's
crazy ideas that I want to try.
Oh, Bill asks, one more thing. Is pickleball your thing now, or are you still trying to play a lot of tennis? Okay, for the record, I know she doesn't like pickleball.
I have
And
played
in fact, it
3
drives her
times.
crazy.
So I don't mind
People that play pickleball. What I don't like is pickleball players that think they have a right to our tennis court.
I know, we've had this debate. I love tennis. This is my primary sport. So Kelly and I played many times. We're similar levels. She's a very good tennis player. But I do enjoy, like I play pickleball Wednesday night. I do enjoy playing. I don't take it very seriously like some of these guys do. Because I think it's like, yeah, it's a game you can play with a 70-year-old woman and me and still be fun. Like, it's awesome in that respect, right? Like, it doesn't really...
Well, that's the benefit because, like,
yeah, it's super cool.
Kind of, I compare it to like going bowling. Like, you don't have to be a great bowler
You
to
have to
go
be
out and have like
competitive.
a fun team building exercise
That's right.
around bowling.
That's
So I
right.
can do that with pickleball. Like, I've taken my team and we've gone to the local chicken and pickle place and had like
Oh.
a great fun time playing.
We don't have
pickleball.
those yet. That's awesome.
We can't
I
do
love
that
it.
with tennis. Like, that's
No.
not an option.
For tennis, so
No, you had to be good enough to play, and that's like it is a harder sport. That is for sure. So, all right, Kelly, thanks so much for doing this. Super fun. I hope people enjoyed it. I thought it was great, and great to hear your thoughts. And as always, and you're one of the most knowledgeable people in wrestling I know, and so it's always great to
thank
hear
you.
what you're doing. So,
Well,
Thanks for doing
asking
it.
me.
yeah, it's super fun. All right, thanks everybody. Thanks for joining. We'll do another one next month. I don't know who my guest is yet. We'll figure it out. So that'll be fun. Let me